Good afternoon, everyone. My topic is restoring ocular integrity of perforated corneal ulcer using host tissues derived from keratoplasty during COVID-19 pandemic. Aim of the study was to report initial clinical outcomes of therapeutic PK for perforated corneal ulcers using host corneal button. Therapeutic penetrating keratoplasty is a surgical procedure to restore globe integrity or to resolve infectious or inflammatory keratitis non-responsive to medical treatment. COVID-19 pandemic caused unprecedented crisis to corneal surgeons. There was an acute imbalance of demand and supply of tissues. We report 2 cases that required therapeutic PK and were managed successfully by graft derived from host tissues of patients undergoing optical PK for PBK. Case 1, 26-year-old female, history of trauma with wooden stick for 6 days duration. Patient had a complaint of redness, discharge and decreased vision in right eye and was previously treated with eye ointment, itraconazole, moxifloxacin, tobramycin, atropine ointment with no symptomatic relief. Systemically, she was okay. Ocular examination, visual acuity was hand movement close to face with PR accurate in all quadrants, and cornea had a perforated corneal ulcer of greatest diameter of 5.1 into 4.2 mm with 0.5 mm diffuse stromal infiltrates in surrounding corneal stroma. Anterior chamber was shallow inferiorly and fundus was anechoic on ultrasonography. Preoperatively, all the viral markers were non-reactive. KOS showed filamentous septate fungi and Sebrodextrose agar has Aspergillus species. Patient was started on eye drop, natamycin, homatropine, moxifloxacin and tablet ketoconazole, and therapeutic penetrating keratoplasty with intracameral injection of voriconazole was performed using glycerine preserved non-vascularized host tissue obtained from optical PK of PBK patients. Size of the graft was 7.5 mm. Post-operative day 1, graft clarity was 0 and graft host junction was well opposed. Anterior chamber was formed and patient was maintained on the same medications as advised pre-operatively. Post-operative day 1, graft clarity was 0 and graft host junction was well opposed and anterior chamber was formed. Patient was maintained on same medications as advised pre-operatively. Patient was followed up weekly for 1 month and graft clarity didn't improve. Graft was completely epithelialized at 1 week. There was no recurrence of infection and follow-up of the patient was done through telemedicine services because of COVID. At 1 year follow-up, graft was completely opaque with inferior conjunctivalization of the graft, and ASOCT was done, which was suggestive of thick epithelialized graft with well opposed graft host junction. Optical PK was performed after 1 year. Final visual acuity at 1 month post-operative visit was 636 parts with a phakic correction. The histopathological examination showed stratified squamous non-keratinized 5-layered epithelium. These are the pictures. Second case was 68-year-old female presented to our department in February 2020 with complaints of redness, pain, photophobia and decreased vision in left eye for the duration of 1 month. Left eye vision was PL positive and PR accurate, and on cornea had a perforated corneal ulcer of size 4.7 into 4.5 mm with Descemet membrane folds and shallow anterior chamber. Preoperative investigations, viral markers were non-reactive and KOH wet mount showed filamentous septate fungi and SDA had Aspergillus species. Systemically, patient was within normal limit and patient was started on eye drop natamycin, homatropine, moxifloxacin as well as tablet ketoconazole. And same as previous case, therapeutic PK with intracameral injection of voriconazole was performed using glycerol preserved non-vascularized host tissue obtained from optical PK of PBK patient. Size of the graft was 7.5 mm. Post-operative day 1, graft clarity was 1+, graft host junction was well opposed and anterior chamber was formed. AC details were not visible. Patient was maintained on the same medications as pre-operatively and no exudate or hypopyon was noted. Patient was followed up weekly for first 3 weeks. There was no recurrence of infection. Graft was well epithelialized at the end of 1 week. Due to widespread pandemic, he was followed up by telemedicine services. At 1 year follow-up, visual acuity in the left eye was perception to light with projection of rays accurate in all quadrants. Graft clarity was 0 with devascularization at 4 and 5 o'clock positions. ASOCT at 1 year was suggestive of thick epithelialized graft with peripheral anterior synechia superiorly at graft host junction, while peripheral anterior the optical triple procedure was done at 14 months when the donor tissue became available. Patient's final visual acuity was 20/80 at 1 month post PK. These are the pictures. During lockdown, the number of donor corneas collected and thus emergency therapeutic keratoplasty performed decreased significantly. Tissues from other eye banks could not be transported. People started glycerol preserved corneas or scleral patch graft for therapeutic purposes. We anticipated tissue scarcity due to COVID-19 pandemic and promptly preserved 4 host tissues derived from optical PK and glycerol. Tissues were utilized on day 6 and day 8 of their storage respectively, because even glycerol preserved corneas were not available to us. Take home message: therapeutic PK using host tissues obtained from recipient of optical PK is a safe and effective option to restore ocular integrity in cases of emergency. During the shortage of fresh or glycerol preserved corneas, optical penetrating keratoplasty is required for visual rehabilitation at later date. Thank you so much.